Good afternoon. Let's bring our hearing to order. Pleased to welcome you to Assembly Health and Human Services Budget Subcommittee number 1. We're looking forward to a rigorous discussion on issues related to public health and overall health. We ask our panelists, as always, if you could keep your presentation concise and brief and high-level overview so that we can spend the majority of our time for questions from the members and questions and comment from the public. With that said, let's begin with our overview, and we will call our panelists forward to provide an overview of the Department of Public Health. We welcome Dr. Karen Smith, the Director of the Department of Public Health, Barbara Taylor from the Department of Finance. We'll have a representative from the LEO's office as well. Thank you. Welcome.
Thank you.
We are ready when you are.
Okay. Thank you very much. Chairman, members of the committee, I appreciate the opportunity to speak to you today. My name is Dr. Karen Smith. I'm the Director of the California Department of Public Health and the California State Public Health Officer. I thought I would actually provide, instead of an overview of the department, which I think you're going to get a very good picture of in the next couple of hours or so, but rather to answer the two questions that the committee submitted to the department. The first of those two questions is to please explain how the department sets public health priorities for the state. Ideally, public health priorities are set for any community are chosen by first conducting a thorough assessment of the health issues in that community. That assessment then informs conversations with the community, which then engages with the health department in a data-informed agreement on community priorities. That process then turns into a community health improvement plan in which strategies and tactics are employed to address those priorities, responsibilities for who's going to do what are assigned, and outcome measures that can be used to measure progress are identified. A key feature of public health prioritization and planning is that it's inherently collaborative, reflecting multifactorial genesis of the health issues that confront us today and the interventions needed to fully address them. This seemingly straightforward process is, in fact, quite challenging in a state as diverse as California, and particularly from the level of a state health department that is as complex as the California Department of Public Health. The narrowly focused, highly restricted federal funding and funding from special fees and special funds that make up over 95% of the department's budget results in many, over 200 actually, largely isolated and independently functioning programs for which the funder typically targets specific priorities and allowable activities. And in addition to that, the funding that we receive is not proportionate with the burden of the various issues on the public in general. For example, chronic diseases make up the predominant challenge to health in California, and yet it's an underfunded activity. So I think I'll cut this short to say that we do, in fact, have, however, a statewide health assessment and health improvement plan in the general sense, and that's the Let's Get Healthy California Task Force. And over the past year, the department has begun a process of every program looking at Let's Get Healthy California and assessing where their program is actually helping to make progress toward a particular goal area and which of the indicators, there are 39 indicators of performance in the plan, they are actually addressing. And through this process, we hope to come to some agreement and some alignment around the priorities for the department overall. At the same time, we are taking all of the various strategic plans and community plans that we've developed within the different programs at the direction of the funders and doing a crosswalk of those. And then taking those as well and in the light of the framework of Let's Get Healthy and coming up with some overarching priorities. And then we will be actually taking those priorities to the local health departments, which have expressed interest in having shared priorities between both the state and the local level, which has not happened in a very long time in California. So I think over the next 18 months, we're actually going to be able to identify fairly clearly some very specific priorities for the department and in general for the overall public health enterprise, because public health is by no means just the governmental public health department. The second question that you asked us was what are or should be the state's public health priorities in 2016. And again, our overall priorities are include those within the Let's Get Healthy Task Force report, which the goal areas in there encompass pretty much everything that the department works on and is interested in actually improving. At the same time, we really do want to work with local jurisdictions to have them assess whether Let's Get Healthy doesn't similarly provide priorities for them and a structure in which they can further develop their health improvement plans. We also have as a priority responding proactively to public health emergencies such as the spread of Zika virus and the ongoing and increasingly severe opioid epidemic, which we currently have quite a lot of work ongoing in. And then finally, we want to look really deeply internally in the department and assess the degree to which we are or are not addressing the foundational public health services and capabilities that every Californian has a right to deserve from their state Department of Public Health. So I'll conclude my comments there.
Thank you, Dr. Smith. I'd like to take a moment to establish the role for the committee. If staff would, please call the roll.
Thurmond.
Here.
Bonta. Chu. Grove. Harper.
Present.
Thank you. Let me ask anything from finance on the overview from the Department of Public Health?
No.
Anything from the LEO's office? Any questions from committee members? Seeing none, is there any public comment? Thank you for laying out that overview. Stick around. I'm sure we'll have other topics to discuss. We're going to move on to issue number 2. Thank you. Genetic Disease Screening Program Estimate. We welcome from the Center for Family Health, Connie Mitchell. Also from the Center for Family Health, Leslie Gaffney. We'll have representatives from finance in the LAO's office.
Hello, my name is Connie Mitchell. I'm the Deputy Director of the Center for Family Health. And in the Center for Family Health, we have 3 divisions. All of them are very devoted to the care of families and women of reproductive health and infants and children. So genetic disease screening program, which is the first item on the agenda, is one of the divisions. We also have maternal, child, and adolescent health. And our 3rd division is WIC, the Women, Infant, Children Nutrition Program. I have here today Leslie Gaffney, who I'm proud to introduce today as our new Assistant Deputy Director. You may know her previously. She was also the assisting and at one point acting director for genetic disease screening, so this represents a promotion for her, and really excited to have such an experienced person here. After 8 years of trying to recruit for a leader for genetic disease screening, we finally recruited someone, and he's in the audience, and so hopefully at the next hearing you'll get to hear from Dr. Richard Olney. He's new to us, and so we're really pleased that we were able to recruit him from the CDC. He's nationally known and regarded for his work in genetic disease screening and in birth defects monitoring. So with that, I think I'm going to turn it over in the name of time and ask Leslie to address our first estimate from GDSP.
Congratulations and welcome.
Thank you. So I'm going to give you an overview of GDSP's budget and then walk you through the proposed fee increase for newborn screening. Overall, for 15-16, GDSP estimates total expenditures to be $114.4 million, which is a decrease of $4.1 million compared to 2015 Budget Act. We expect that the 16-17 expenditures will remain essentially the same as 2015 Budget Act, which is $118.4 million. Reductions in 15-16 are attributed to changes in the caseload for both newborn screening and prenatal screening, as well as the fact that women with positive prenatal screening results continue to choose non-invasive prenatal screening as a covered benefit in very large numbers, more than we actually expect, as opposed to choosing amniocentesis or chorionic villus sampling, which are more invasive procedures. So we're pleased to see that. And then breaking down our state operations and local assistance, state ops for 15-16 is projected to be $29.3 million, which is a slight increase of just under $500,000 to cover baseline adjustments for salary benefits, other state staff, and facility costs. And 16-17 expenditure projection is $26.3 million, which is a net decrease of $2.6 million compared to Budget Act from 2015. We are moving $3.9 million from state operations to local assistance. When we first started screening for SCID, severe combined immune deficiency, the money was allocated in state operations, and we had a lab in a lab concept where we had one laboratory at Richmond doing the work. Since the FDA has approved the kit, we have moved that testing out to our regional laboratories with all of the rest of the newborn screening testing, and that becomes part of existing contracts which are already funded out of local assistance. So there is a need to move that money into the local assistance budget so we can pay. So that is happening this cycle. For local assistance, the 15-16 expenditures projected to be $85.1 million. That's a decrease of 4.6 from Budget Act, and that's the money we talked about earlier because of caseload and the choice of follow-up for prenatal screening. In 16-17, the expenditures are projected to be $92.1 million. That's a net increase of $2.4 million compared to the 2015 Budget Act. And this is attributed to increased spending in newborn screening to test for adrenoleukodystrophy as required by AB 1559. I will come back to that subject. Revenue projection for 15-16 is $117.9 million, which is a decrease of $3.5 million compared to Budget Act, and that, again, is due to caseload. The revenue for 16-17 is projected to be $124.1 million, an increase of $2.7 million over 2015 Budget Act, and this is directly attributable to a fee increase for newborn screening for ALD screening. I don't know if you recall last year when we came to you, we were talking about adrenoleukodystrophy screening and the fact that AB 1559 would require us to add it to the newborn screening panel once the federal government added adrenoleukodystrophy to the RUSP, which is the Recommended Uniform Screening Panel. And that's the list of newborn screening disorders that the federal government recommends that states screen for. So it's sort of in a moving target, and we've been waiting for Secretary Burwell to add it to the panel. It was referred to her in August, and this February 16th, she made the recommendation, and it's been added to the panel. So we are moving forward per our mandate to add screening for ALD this summer. We are committed to going back and taking all of the specimens that were received at our laboratory on the day she added it, February 16th, and making sure all of those babies get tested for ALD. Luckily, it's one of those disorders that doesn't have to be picked up right after birth, so we have a little bit of lead time. But in order to do that, as we mentioned last year, we will need a fee increase to cover the cost of testing and follow-up and educational materials. The dollar amount has stayed the same since we did the bill analysis several years ago. It's $11 per specimen. So we are hoping to raise the fee for newborn screening from its current fee for the test of $111.70 to $122.70. There is also an additional $1 fee that's charged for the actual testing kit, the filter paper. So this is a cost that we bill to the hospital, and the hospital in turn turns around and bills it to the patient's insurance company or Medi-Cal, and for the very rare case when somebody's a private pay patient, to the patient. Historically, we have had no concerns or oppositions to fee increases for newborn screening, so we don't anticipate any this go-round.
Thank you. Anything from Finance? From the LAO's office? Any committee member questions? Any public comment? Thank you. Seeing none, we will move on to issue number 3. Thank you for your presentation. We invite Ms. Mitchell to stay with us as we move on to Women, Infants, and Children, the WIC program estimate. We'll hear again from Ms. Mitchell. We welcome Christine Nelson, the Chief of the Women, Infants, and Children Division, and we'll hear from Finance and LAO's office and public comment.
Yes, and
You're
this
ready.
is Chris Nelson. She's the division chief for WIC, and so she'll be reviewing the both the program estimate and then follow up with the BCP, the next two items.
Welcome.
Thank you. Thank you very much for the opportunity to address the committee today. I'll provide a brief overview of the WIC estimate and highlight two key areas of the program, EBT and program participation, and then follow up with the responses to the specific questions. So the estimate includes projections for both participation and food costs broken out by 5 participant categories: pregnant women, breastfeeding women, non-breastfeeding postpartum women, infants, and children. And each of these categories have specialized nutritional needs that influence food costs. Participation in California in the WIC program has declined since mid-2012, and this decline is consistent with national trends, and I'll address that a little bit more in just a moment. For this estimate, we project participation based on actual data for prior years, as well as the 5-year trends and projected number of births. And this is an adjustment from a year ago when we did not include the 5-year trends. Last year, we implemented a new methodology, and we've refined that this time. For food costs per participant, we have not changed the methodology. We continue to determine the food costs by looking at historical data and then adjusting for inflation using the Consumer Price Index for food at home. And more details about the individual food costs by participant category can be found on page 18 in the estimate if you're looking for that specific level of detail. I know there's some interest in some of those categories. So overall, with declining participation and a minimal increases in food costs per participation, overall food costs have declined slightly, but revenue has remained relatively flat, and we continue to have sufficient funding to serve our participants and some room for growth. Next, I'll provide an update about the transition from paper checks to EBT, and we continue to work to prepare for that transition. As you may know, all states are required to transition to EBT for WIC by October 2020, and so far 13 states have EBT for WIC. In order to have EBT for WIC in California, we need to have two things. First, a contracted EBT service provider that handles the banking transactions at the stores. And second, we need to replace our IT system that's used both at the state and in the local agencies so that we can issue benefits in a different way and also hold all the data for all the individual UPC codes for the authorized foods at the stores. Public Health has partnered with the Department of Social Services and the Office of Systems Integration to secure a single EBT service provider for California. OSI has recently awarded that contract, and because that contractor is not the current EBT service provider for Department of Social Services, that new contractor will first focus on transitioning all the social services programs over to their new contract. And while that is happening, we are working on replacing our IT system. Department of Public Health has also partnered with Office of Systems Integration to oversee that project to replace the IT system, and that new partnership is detailed in our BCP for EWIC. OSI is completing the request for proposal to hire a company that would both bring a system to California and roll it out throughout the state. So they'll train state and local agency staff, prepare them for this new system. Let's see. Our office has recently developed an EBT and what we call a MIS, which is the Management Information System Readiness Work Group with local WIC agencies to ensure that they're actively involved in the planning efforts and ready for this transition. Next, I'll provide an update about program participation. And while California continues to have the highest coverage rates of all states, we do have some room to grow and improve. So I'm going to highlight 3 components of our plan for recruitment and retention. First is data, second is a program review, and third is communication. So looking at data, understanding and using the data is critical to targeting our technical assistance and outreach strategies and identifying best practices. So last year, you may recall that I spoke about our work to create a methodology to replicate USDA's estimate of eligible populations, but at a local level. So the federal government has an estimate of the eligible population just at the state level, and we wanted to break that down at the local level. And we've completed that methodology and have good information out of that. But now that we have that methodology worked out, we can replicate it ongoing so that we'll have more current data and more current results from that study. In addition, the WIC division partners with the Maternal, Child, and Adolescent Health Division on an analysis about why pregnant women that are eligible for WIC don't enroll in WIC during their pregnancy. And knowing the reasons why they don't enroll in WIC will help us to target our outreach strategies and messages. The findings of that most recent analysis is just about complete, and we're presenting it next week at the California WIC Association conference so that all local agencies and stakeholders can hear the results. In addition, we are beginning partnerships with CalFresh and Medi-Cal to link data to determine where there are gaps in co-enrollment. This information will help us target our technical assistance and outreach strategies again, and this work is included in the BCP, which I'll address a bit later under issue number 4. In addition to studying data, we're reviewing our program to identify areas where we can improve processes and services to improve program retention. So some examples of that are coordination and modernization of the enrollment process, and again, that's included in the BCP in issue number 4. Improving communication with current participants, ensuring that our services are of quality, are relevant and engaging for WIC families, and ensuring access to stores, the ability to identify the authorized foods once the family's in the store, and the ease of processing the food vouchers at the cash register. Lastly, communication with the public and stakeholders is critical to reach new families. We're always striving to strengthen state and local outreach efforts with the public and community partners and providers, and ensure consistent and supportive messages and other programs that serve the same population. Your agenda included 3 specific questions. Shall I just move into that area?
Please.
Great. So question number 1, yes, for the past few years, we have reverted funds to the federal government. For the food grant, we revert about 12% of our total grant, and then we get about half of that back each year in reallocation. So the U.S. Department of Agriculture has a standard process where whenever states or territories revert funds back, they reallocate it again the next year. So in our NSA grant, which is the Nutrition Services and Administration grant that funds all the local assistance in the clinics as well as state operations, we typically revert about 6% of our grant, and we get all of that back the following year. So the last 3 years we looked at how much we got back, and actually in the current year we got a little bit more than what we reverted last year. Question number 2 is about modernization of communication, and we're finalizing a website that's designed to be used by mobile devices. It can be used by the public to assess eligibility, find enrollment sites and authorized stores, and review our authorized food lists. It can also be used by WIC families to access information that's specific to their appointments and their services. So there'll be a module in that where a family could log in and see their own appointment, that sort of thing. The EBT service provider will also have an app that WIC families can use to identify specific foods that are authorized. And locally, many WIC agencies have a strong social media presence and offer nutrition education online. Local WIC agencies also use texting to communicate with their participants about appointments and services. And lastly, I'll address ongoing stakeholder participation. We work very closely with our 2 primary partners, the local WIC agencies and the authorized stores. In addition to having state staff assigned as liaisons to each local agency and each store for ongoing communication and assistance, we include local agency staff on a variety of work groups, such as reviewing nutrition standards, developing nutrition education and breastfeeding messages and curriculum, identifying and addressing training needs of staff, MIS and EBT readiness, as I mentioned, and previously we used local agencies to contribute to our funding methodology. We have monthly webinars with local WIC agencies to provide updates on program policy and development and operations, and last fall we hosted our first annual meeting of all local agencies. In addition, early this year, our leadership team has begun to visit local agencies across the state so that we can talk face-to-face with the local directors and staff about program priorities. Last month, with members of my team, I visited local agencies in the Central Valley and in the Sierra Cascade area, and last week we went to the East Bay to visit local agencies from around the Bay Area. We also have routine calls and webinars with the vendors and their associations to discuss program policy development and operations. These calls are open to all vendor stakeholders, and state staff regularly conduct outreach to vendor groups and their associations to expand participation in those calls. And we encourage stakeholder participation before any final actions are implemented on the proposed regulations. While our stakeholder participation with local agencies and vendors is very strong, we would like to expand our partnerships with other programs that serve the same population, and I'll address that a bit more under Issue 4, because expanding these partnerships will help us to reach and retain families in the program and provide quality services to improve healthy eating habits.
Thank you, Ms. Mitchell. Anything from Finance? Anything from the LAO's office? I was wondering, you talked a little bit about the decrease in participation, and I know you're going to, provide this report, I think you said, starting next week. Could you give us a few highlights about, what the findings are about why the decrease in participation?
So we have 2 reports that we could share. One is posted on our website now at what we call it the Eligibles Report. So this is the report where we mirrored USDA's methodology but did it at the local level. And what we can see is that while California does have a high coverage rate overall, there's a lot of variance across the state. So we see that both in participant categories for pregnant, postpartum women, and infants, our coverage rate is very high, but for children it's much lower. And a statewide average for children is about 73%, which is much higher than other states, but definitely has room to improve. The coverage rates in other areas of women are around 90%, so we definitely want to do better with children. We also see a lot of variance across counties. So we have counties that are well below 50% overall and counties that are up above 90%. So we want to be able to work with those individual county areas, local agencies or county health departments to understand what are the barriers that are happening there in their own geographic area. Is it something that's happening in their community? Do they need sites in different places? Is it better coordination with other programs? We also want to study those areas that have very high coverage rates to see what are they doing that's working so well. Then the other report is why pregnant women don't enroll in WIC. And so what we are seeing from that is, I think there was an assumption that the reason would be people didn't know about WIC, but they do know about WIC. They didn't know that they qualified for WIC, so they didn't understand all of the eligibility requirements. For example, if someone has a job, they think they didn't qualify, but they still could qualify for WIC. And the second most common reason was they didn't think that they needed WIC, so they didn't really fully understand the benefits they could get from the program.
Thank you. Tell me again, what's the dollar amount that the total WIC package would mean to a family per month? What does that represent in dollars?
It varies by category, so let me look at the numbers.
Let's say, for example, the program with children, roughly. It doesn't have to be exact.
$58.
Got it.
It's more for infants because infant formula is more expensive. But the average cost per participant for pregnant and pregnant breastfeeding is about $56. Non-breastfeeding postpartum women is about $40. Infant, $115. And children, $49.
Thank you. Do you have a way to, survey participants to find out what they find helpful, not helpful, barriers, obstacles, as a way of also, I know you have this group that's doing, a study, but do you have a way to talk directly to the participants and find out what are opportunities and barriers, and really a way to increase participation?
Absolutely. So that happens both at the local level, where they do client satisfaction surveys every year, and we're also working to develop something more on a statewide basis so we can reach out to participants as well.
Do we have a way to just talk to parents?
Yes.
I admit I am guilty. Every time I get that call and they say, this will just take 30 seconds, click, I hang up. In 2 seconds, I'm going to hang up. And sometimes if someone would just talk to me, and I just slow down and listen, they might be able to get information that could be helpful. I'm wondering about in this case as well.
We do hear a lot from the local agencies about their experiences in the clinic, of families that come in that share information about this works really well or this part's kind of difficult to come back for. So we hear those kind of anecdotal stories as well, which are very helpful to us.
And is the outreach provided in multilingual ways? You know, I'm just thinking about the diversity of our state and how it continues to diversify. And, you know, I'm wondering if there's a correlation between people not enrolling because of language barriers and they may not know how or may not be aware.
Right, absolutely. And so some of the information that came from the study about pregnant women not enrolling in WIC, we're able to break it down by demographics as well. And we saw a little bit of different variances on demographics. So that's something that we need to pursue as well.
Got it. And it's obviously something I'm very interested in. The committee's interested in. We want to make sure that our families have access to the best nutrition that they can. When we've got communities where kids have obesity and diabetes and other illness as high as 50%, we want to make sure we're taking advantage of every program, not to mention just the costs for many of our families. And so anything that's a benefit, I'm always interested in how we maximize and I understand this is a nationwide trend, not just in California, but I'm very interested in what we can do to maximize that, and would like to continue to work with your office, and if you would work with our office on what you're finding and how we can maximize participation.
Yes, we'd love to. Thank you.
Thank you. Is there any public comment for this? Please come forward.
My name is Karen Farley. I'm with the California WIC Association. Oh, here it is. I'm Karen Farley, the Executive Director of the California WIC Association, and I wanted to make three quick points. One is we wanted to applaud the WIC program for really looking at the real costs of providing the services. Chris just provided you some of those details of each type of participant, and that really helps the local agencies be reimbursed for what it really costs to provide those high-quality services, and that's not something that was always done that accurately, and it's really great to hear that. Second point is we encourage the program to really keep a really strong public health, nutrition, and lactation workforce. Besides the food, the nutrition and breastfeeding support is what you get, and that's really important, and we have good outcomes to show from having a strong workforce. And we're also big partners in healthcare reform, so really having that strong workforce out there will address the chronic disease you're describing. And thirdly, we really encourage a strong communication network with 84 local agencies and over 3,000 employees. That's a huge number of people to address and keep on the same page or move along with new initiatives. So we really support all those avenues for communication. And I wanted to mention, as stakeholders with grant funding, California WIC Association has used some of our money to provide work and a look at inclusion of millennials, African American families, and men and dads, and we're sharing that out with not only WIC or any other social service agencies that want those materials. So,
does that include Spanish-speaking families as well?
We haven't looked at that population. We just looked at those three groups right now, and we have reports or toolkits or different things for staff use for best practices or recommendations for things we need to change.
Thank you.
Thank you.
Any other public comment? Okay, seeing no other public comment, we will move on to issue number 4. Again, welcoming Ms. Mitchell and Ms. Nelson, Finance and LAO, and then public comment.
Very good.
We're ready when you are.
So I'll give you for issue number 4, families that we wanted to make sure everyone's aware that families that are enrolled in CalFresh or Medi-Cal are adjunctively eligible for WIC. So we want to know where there are families that are enrolled in either of those two programs but not in WIC, and vice versa. I know CalFresh is also very interested in knowing about families that are enrolled in WIC but not CalFresh. And so we're partnering with CalFresh and Medi-Cal for a data sharing agreement, and then ultimately for data linkage, and also to improve outreach, referrals, and enrollment strategies. So in this BCP, we are requesting 2 research scientist positions to focus on the data linkage and analytics in order to determine where we have hotspots of low co-enrollment rates so that we can target outreach efforts and reduce barriers. And we also want to look at areas with higher co-enrollment rates so that we can share best practices. We are also requesting 2 health program specialist positions to focus on improving outreach, referral, and enrollment strategies. And we'll work with counties and local agencies to review administrative and enrollment processes in order to reduce barriers and review the warm handoff models, the referrals from one program to another. We'll also develop targeted outreach strategies and messaging and work with other programs that serve our population.
Thank you. Anything else for the department? Anything additional?
Yes, we also have we have another BCP, so do you want to move on? Or?